My name is Gerit Pfuhl. I'm at the University of Norway, and it's a really good place during this pandemic to be in Norway. I will talk about our cross-national study where we looked at perceived efficacy, but also mental health and paranoia during the early phase of the COVID-19 outbreak, and actually 6 countries where we have over 50 respondents. And the data I present is part of it that will be soon coming out at the Royal Society Open Science. That's the March survey, and fresh from you, really live coded during the last few hours, the April data. We are currently running the July data, actually. So I would like also to thank 2 of my PhD students, Martin Mekele and Christopher Clevier. They have helped in designing and brainstorming the survey. And then the cross-national data collection was together with Niv Rege from Israel, Natalia Dutra, Reinaldo Sobrino from Brazil, and Ricardo Tamayo from Colombia. We also got quick help for an Italian translation by Giovanni Briganti. Unfortunately, not that many participants. Yeah, you also find my contact details on this slide. Okay, so what is the background for our study? Apart from that, our lab got closed and we had to find something to do. Well, we had a lot of other stuff to do, but we had a bit of a pressure to produce something, given that we early knew that this is a marathon and not a sprint. And we actually worked in related fields. Particularly, we looked at paranoia and bullshit receptivity, as well as we look at generally depression and psychosis, part of my lab. So we then set out a survey really looking foremost on, okay, how do people perceive the threat and how do they cope with it? And that is nothing new. That has already been in the 1970s described by Rogers and this protection motivation theory. So kind of a fear appeal communication. And what you have there is 4 components. How noxious is the threat? How probable is it? But also how effective can you cope with it? And then later added by Maddox and Roger, also the self-efficacy. In addition, we also saw definitely the effectiveness or the coping strategy, and thereby also the resilience depends on your knowledge, meaning distinguishing between epistemological truths, really facts, and conspiracy theories or just fake news. Trust, but also general, we had to measure mental health. So we, in the April survey, looked more into detail by asking about trust in government, but also health authorities, scientists in general, but also whether they do give enough information and they are confident in, also transparently reported or communicated. We did ask about belief in conspiracy theories, as well as some factual knowledge about the virus. We measured the general distress with the core 9. So we removed the item of suicidal ideation because we had no chance to help participants who would actually score very high there. And then for ethical approval, of course, we cannot then ask about that. Yes, and we also measured paranoia with the CAPE. For those who are not familiar with it, the long version is the Community Assessment for Psychotic Experience, has 42 items, 3 subscales, negative and depressive, as well as the positive items. And we use just a subset actually of the positive items, namely those that really go about paranoia and hallucinations. Okay, how can we actually think about it? So think about the information you had in January 2020. This is very hard because we all suffer from hindsight bias. But roughly, if you are an epidemiologist, you had lots of knowledge about SARS, MERS, influenza, or swine influenza, and really what needed to be done. And there was so far very little data you had about this new virus. So all your responses and recommendations should be based on general knowledge, epidemiological knowledge. So contact tracing and testing. It then, of course, your knowledge increased. So you could then adapt this to even more fine-tuned recommendations how to respond and communicate about it. Though what we also have to consider is actually what a naive participant may actually see or think about it. And for them, they are not the epidemiologists. So they may, and that differs actually really by country. The Asian countries had experience with SARS and MERS, or the also some other, but definitely some countries, and it's true for Norway, definitely had no experience with SARS or MERS. So, and pandemic that was, well, maybe 1918, but you haven't lived there. So for them, all the information you've heard about and the responses your government made to that would be based really on the information you have about SARS COVID or SARS-CoV-19. Okay, so how can we study it? We looked actually at risk perception. So with 3 items in the March survey and 5 items in the April survey, mostly about how much they think they will be infected by the virus in the next week or in the next 2 months, and how severe, whether they need hospitalization. Then we also ask about protective actions, including also hoarding. I will not report them here. So mostly we ask about do they engage in hand washing, social distancing, but you also ask whether they do these actions for themselves or for others. Again, unfortunately, I refer you to our paper. In April, we ask far more protective actions or behaviors they will engage in, as well as whether they keep a regular schedule and generally feel this more as a thriving opportunity. We also ask about the impact of restrictions. So there are about school closings or university closings, but also cultural or sport events being cancelled, transportations, but also a change from working at your company to having to work from home. Crucially, we ask how much they actually think their own reactions to those restrictions or to this crisis are efficacious, those of others or actually those of the government. Yes, so what we see here is the direct impact on daily life among the nearly over 80% of participants that already in March, around the mid of March, were already or stated they were affected by the corona in their country. And actually, if you look closer at it, green means they're stating it's not impacting their daily life very much. And it's still looks good for school closings and university closings. And that has to do that more than half of our participants were actually not attending schools or universities. They were more fussed about actually transportations and as a public transport and not being able to travel. Those who were not yet, as I stated, really in early March, that hasn't touched them yet, the crisis, the pandemic, responded very similarly. Now, what about risk perception? Here we actually see that most of them actually are around halfway on our visual analog scale from 0 to 100. There are some country differences, particularly the younger sample from Colombia actually has a slightly lower perceived health risk, compared to the other 5 countries where the age is very similar, around 33 years, whereas in Colombia it's really around students in 20-ish. And we don't see much of gender differences plotted here just for avoiding that you ask about it, because in the literature is often described that health risk perception actually differs between the genders. Yes, we also have, as in the previous talks, sampled, or because it's a convenient sample, more women than men who participated. Since it's a very low number, those who said they have another gender than male or female are excluded here. It just was a handful of participants. Now in April, actually, as you can see here, the perceived health risk is far lower. So now 1 month into the pandemic, in most of those countries, people actually treat their own personal health risk. They rated it now lower by 10 to 15 points. So yeah. Now, what about resilience then? We talk about resilience when actually the protective factors or the sum of the protective factors, so to say, is larger than the risk factors. We defined here as protective factors engaging in protective behavior, like keeping social contact, even if it's not physically face-to-face possible, keeping a regular schedule, but also having trust in government, health authorities, and scientists, as well as thriving. Whereas risk factors are education, socioeconomic status, high worry and fear, perceived health risk, the efficacy of the reactions, as I will show in a bit, and also stating that the government is overreacting, that goes in the direction of infringement of freedom. Now, here are our protective behaviors during the lockdown we ask our participants about, and during a day how much they engage with it. It's again, so green means that they do this a lot, so it's the majority of the day they're engaging in that, and quite many actually work from home in one or another. But many also, you see this in the here, they do exercise, they do engage in emotional support 30 to 2 hours per day, as well as they engage in kind of grocery shopping or playing, or actually video or text messaging. So there's a lot of protective behavior people do actually. So now when we sum those factors, protective factors, we see that they score quite high. So a lot of our participants actually reach a score over 16, so more than 2/3 of the maximum score of 24. And somewhat encouraging for us is the risk factors. The score is actually lower. So if we calculate a different score, we actually see that for most participants, but not all, there is some resilience. So the protective factors, the sum of protective factors is larger than the risk factors. Of course, it can be discussed whether our scale of protective factors and risk factors are appropriate. Yes. So now one thing that is really interesting, namely, how much do you think the reactions in those crises are really have an effect? And we have to distinguish between the own reactions you're doing, so kind of self-efficacy, whereas those you may see others are doing, your community or your general, your fellow citizen, or that of the government. And to guide you through this plot, we really ask you what predicts how people judge the efficacy. And there's not much going on with age, as Valerie explained in her talk. If the error bars, the confidence interval, cross the stippled line, then there's no significant difference here. So we see on the top, there's no effect of age. And we also have not really a very big effect of gender. We have it a bit for how you see, judge the efficacy of the government. However, I would like to draw your attention actually first and foremost to controlling. That is not so surprising. So the more you think that we can control the outbreak, the more you also think the active reactions of either those you are doing, others are doing, or the government are doing are effective. The reverse is true for paranoia, actually. And actually there it's so that it's, well, whether this is significant, I haven't done yet the dominance analysis, but a higher score of paranoia definitely reduces the efficacy. But worry and fear is really the interesting bit here. So if you are very much worried, that is this bit, then you also think that your own actions are efficacious. But you have exactly the opposite opinion about the government. Now, when we look at this in April, we see kind of, if you look at that, an exaggeration of this when it comes to the government. So the more you are worried, the less you actually think that your government actions are efficacious. So again, there's no effect of age even in the April data set, and a large effect for if you judge that we can control the outbreak. And here also in the April data set, the gender has no effect. But again, we see an effect for paranoia. Okay, how is this now by country? And we know that the leadership differs in those countries. And in March, we see just a general trend that the own, which is here in blue, the own reactions are scored highest, actually. So that's true for South America, Brazil, and Colombia. Own reactions or behaviors are scored higher than that of others or that of the government. The Germans are pretty much equal there. Israel also slightly higher, but also the government gets high grades. Norway also very similar. And in the US also slightly self-efficacy is rated as higher. But this changes quite a lot when we look at our April data set. Now, we still have high self-efficacy in the US, but they really rate the government elections as quite low. Norway is still very high and very similar here. Israel, actually, they rate their own self-efficacy now lower. So that's a bit surprising. We have to look a bit closer into that. And you also see kind of a leadership reflection, maybe. Brazil, they rate their reactions of their own government extremely low. I mean, more or less, as those who follow the news know, there isn't much happening at the state level, not at the because it's also many federal states, their governments are better. Yes, so has this anything to then affect on the mental health? So here we looked at general distress, and the gray line is actually a cutoff point for moderate distress levels, set around 1.5 to 2, this score. And we have quite some participants in all countries that actually score over this cutoff point. And again, it might have to do with this being a younger sample. Colombia scores quite even as with the median above this cutoff point. When we then look at this in the April data, we see somewhat a change, so slight increase for some countries, but not for Norway, for example. So that pattern is a bit more nuanced, and the issue is general distress is not asking about the COVID directly, like our worry and fear items. They really directly ask about, are you worried about getting infected with the virus, as well as we also ask about financial worries. This general distress is really just a general distress measure and not only related to COVID, but of course it is should reflect this. Now, what about paranoia? So here we have our data from March. We find actually that it's a healthy sample, convenient sample. Again, not quite so surprising. The participants from Colombia score some of them really above the cutoff point, which is not so untypical, because again, it's a younger sample and the paranoia scale is sensitive to age. So you score higher the younger you are. And the 10 years difference may affect it. What is still more important is that, again, the paranoia stays roughly the same. So at least we do not see a big jump in paranoia during the 1 month between the March and the April. Though there is a caveat, this is just the cross-sectional data. I did not have time to really look at the longitudinal aspects, really matching the people, because we have both a longitudinal part in it, where the same participants took part in March and April. And we also had participants that only took part in March or only in April. So you unfortunately have to wait a bit for that, or you can ask me a question, but I haven't yet dived into this data. So let me summarize our data. So we don't find an increase in paranoia. There is somewhat an increase in general distress, despite we are seeing also a lower perceived health risk. This may have to do with that, I think we have twice as many participants in Norway than we have in Brazil and in Colombia and in Israel. So they may drive this difference, because they had both a lower perceived health risk and not much change in general distress, whereas in the other countries it may well go that they also have a higher increased health risk, as well as an increase in general distress. Sorry. Generally, we find that our participants have quite some high self-efficacy. So what they are doing, either in protective behaviors or engaging in social distancing, well, 90% of our participants said they do engage in this behavior. Hand washing was even more, 96%. They show quite high self-efficacy compared to the efficacy of what their government is doing. Though we have to look a bit closer why actually self-efficacy dropped in Israel. Main difference by culture, or at least the countries, is seen in how people rate the governmental reactions, as well as also trust. And what I haven't plotted, but you can find it in our preprint, is the difference between those who think their government does enough for fighting the outbreak and those who think their government does not enough. The short version of that is that you find also higher distress among those who think their government is not doing enough. The efficacy of those governmental reactions pretty much reflect the leadership. So as far as we can see, it really goes down from March to April in the US and Brazil, but it stays for Germany, Norway, and Israel. So yes, our March data is actually in press, and here's the link to our preprint. So I'm happy to take now some questions.
Thank you very much, Gerit. Very interesting talk, and we heard some things similar earlier this morning from other speakers. Very quickly, I have a question to ask, although you sort of answered it now at the end. It was about fear and risk, which specifically addressed health, right? People being afraid that they're going to contract COVID. And yes, I was thinking more about the population that are really scared about what's going to happen in the longer term, and especially this group of people who stayed unemployed.
Yeah,
and the government should specifically address that somehow.
Yes, we have this in the data. We ask about the temporal duration of the outbreak and also the restrictions. So on one hand, how long do you think will be this lockdown, last this lockdown, and the other hand, how long will this entire COVID pandemic last? I would have loved to present it, but we had to work on the minor revision of the paper, so that took a lot of time. And we also ask about the financial worries and fears, and especially also what some also presented, the demographic information household data. And yes, I simply hadn't yet the time. Because our studies are pre-registered, or also analysis plan is so that we just do the major data analysis when we close the survey from July. So we have those 3 waves, the March, April, and July, and we don't plan anymore because we have a lot of other projects, all of us. And yeah, so unfortunately, I will only have a full answer to that actually, maybe end of August, early September, when I run through those scripts with the full data set. Because I
Fantastic. No,
really,
it's great that you collected it. We're looking forward to looking at this
Yes.
data as well.
I
Perfect.
can keep you
Fantastic.
posted.
Great. All right. I'm going to thank you again. We'll have to move on to our next speakers. Thank you